Good afternoon. Assalamu alaikum wa rahmatullahi wa barakatuh. Really very much delighted to be here. I am really very much thankful for the organizers giving me a chance to present my lecture over here. Before coming here, I was a little bit apprehensive. As usual, while moving from one country, from your native country to other country, you are always apprehensive. But experiencing the hospitality, seeing the ambience and the kind of attendance over here, I am really very much delighted, very much happy to see you all here, and I am really feeling proud to be part of this 9th SAARC Congress in Dhaka. As usual, the organizers definitely have done a lot of homework to make this Congress a great success. It's being said and a known fact, behind every successful man there is a woman. And there is no denying fact that behind this successful Congress, lot of audience, the kind of audience, see, you can anticipate very well the success of this conference. Friends, the topic which I am going to speak, maybe some of you must have worked on it. It's one of the new technique. I must not name it as new. It's being in practice for a quite long time, but not routinely practiced everywhere. The reasons are known to all of us. Why the elastography came? You know, humankind is always in search of something new, something which may suit to him very well. And necessity is the mother of all kind of inventions. And that is how you can know very well how the Toyota Corolla came and got an invention. In medicine, in clinical practice, palpation is a well-known fact, well-known technique of examination in medicine. For any lesion, you need to do examination by palpation to detect the lesion, to characterize the lesions. But there are fallacies, there are some limitations of those palpations, those age-old techniques. At times you don't have the organ accessibility very well. You find difficulty in accessing the organ. And there are sometimes controversies between different examiners. Lesion is cystic, some would say it is solid, some would say no, it's hard. So while those controversies, gray scale ultrasound was found to be an option, and the method, you know, is very sensitive, is devoid of all those kind of limitations being felt by the fingers. But there are certain limitations inherent to the gray scale ultrasound as well. The subjective characterization, which depends upon the experience of the operator, as well as missing sometimes isoechoic lesions on grade scale ultrasounds. So again you have limitations of grade scale ultrasound, and that is why the elastography was found to be an option to those limitations. What is elastography? It's a kind of stiffness imaging. As you know, all tissues have got certain mechanical properties of strain, and when they are diseased, they lose their strain, they lose their elastic capacity. And that is why elastography was found to be an option to find out what is happening to the tissues. It's a kind of virtual palpation, and it measures stiffness of the tissues in response to the external force applied on that part of the organ or that part of the tissues. Stiffness reduces the strain, and that is how that kind of strain is being measured by the elastography technique. Look at this example, you can understand it very well. See the two models. The one model is having without any pressure. The other model, when you apply pressure, you find little bit deformation. But there is some tissue, some area being represented by the almond representing a hard tissue, which it does not deform. That is what happens in response to the disease when elastography is being applied. You can understand very well further by two models where the particles are being spread in the tissues. When you try to press upon the tissue, you see the deformation in axial as well as lateral direction. That is what happens in the elastography. Deformation of elastic properties of normal tissues take place. Again, to make it more clear, look at those two models in the soft tissues. One is the soft, the other one is hard. When you apply pressure, the softer tissue will show deformation in axial as well as lateral. Lateral deformation is much more than the axial deformation, while in harder tissues, you will not see any kind of lateral deformation, only the axial deformation. That meaning thereby, the pressure and the change is almost equivalent. That means there is no strain, the tissue has lost strain. That is what happens in response to the elastography in harder tissues. There are two methods of estimation of the elasticity, how you measure the strain. Static elastography and dynamic elastography, which is known as the shear wave elastography. Static elastography is the most commonly used in clinical practice, and it is based on two qualities. The one is qualitative assessment, the other one is the quantitative assessment. Look at these two WXG machine. Look at the elastogram over here. You find there are two regions of interest. One is the cursor is being put on the diseased area, the green area which is representing the normal tissue or intermediate stiffness tissue is being, and when both are compared and elastograms are being activated, you find a sinusoidal kind of pattern, and you put the cursor over one of the best the wave pattern, and you will find a ratio. If ratio measures 4, it is likely to be a benign kind of mass. Another example over here, look at this elastogram. You find the blue area, you find the mix of color green as well as the red areas. When you put the cursor over the blue area, which represents the harder area, and compare with the tissue stiffness at the green area, you find the strain ratio, tissue lesion ratio measuring more than 7, that likely represents the malignant kind of lesions. This technique is very simple. Just to briefly, I'll tell you this technique. It's a kind of free hand technique where you select the lesion and then you try to put the probe, high resolution probe, parallel to the chest wall, just exactly perpendicular to the lesion. Try to press this gently, almost equivalent kind of gentle pressure, which you can assess by looking at your sinusoidal kind of wave pattern, and then you switch on after 4 to 5 seconds. You switch on the elastogram, and you will find the image automatically displayed on your monitor. And this kind of applications is being used in many, as you know, elastography is being not only used in breast, but in fact in breast, in thyroid nodule, in the lymph nodes as well. So my topic is basically how the elastography is going to help in kind of breast lesions, and that too which are more likely to be a kind of intermediate kind of lesion. Look at this, the image which represents the assessment on the basis of color elastogram. You see the grayscale image where you find a hypoechoic lesion, rather representing a cystic lesion, and see the enhancement pattern. And with this enhancement pattern and the lesion being cystic with well-defined boundary, little bit irregularity at periphery, the lesion was on the basis of ultrasound being scored as the category 4 and 5. But when you put the elastogram, you see the difference between the elastogram. Not only the center is being representing blue color, in fact the periphery is being also infiltrated, that represents the desmoplastic reaction. So on the basis of the color elastogram, it was scored and graded as BIRATS or score 5 or BIRATS 5. And it was proved to be invasive ductal carcinoma. Look at the another difference over here. You see the grayscale ultrasound where you find little which lobulation and irregularity and ill-defined boundary. And on the basis of grayscale, you will definitely label it as BIRATS 4 or 5. But when you put elastogram, you find the lesion being represented as even lobulation is being represented as blue, but the periphery is not being represented by any blue color. That means the periphery is not being infiltrated. And again proved to be a BIRATS 5 category, a kind of ductal carcinoma. Look at the image over here. You find a hypoechoic lesion representing almost a kind of on grayscale ultrasound. It seems as if it is a fibroadenoma, a kind of hypoechoic, well-defined boundary. But when you do elastogram, you find the center as blue, while the periphery as mix of color. And on the basis of elasticity, it was graded as grade 4 and proved to be a serious kind of invasive ductal carcinoma. Another lesion over here, you see the well-defined, very well-defined, smoothly marginated, no infiltration, no lobulation, no irregularity, and no calcification at all. And definitely on the basis of ultrasound, you will label it as grade 2, R score 2, and BIRATS 2. And on the elastogram, you find a mix of color, a kind of mosaic pattern, which is commonly seen in cases of BIRATS 2 category, a case of fibroadenoma. So on the basis of their study, Huisi et al. Have followed their study and have done a representative study on the basis of color elastogram comparing the mammogram, sonography, grayscale ultrasound and elastography. And they have come out with the result that if you combine sonography as well as elastography, this accuracy is much higher compared to the mammography alone, compared to the sonography alone. So in their study, the accuracy came out to be 93.9%, which is quite high, significantly higher than the mammogram and the sonography alone. Now, going back to the same representative study, when I conducted a study based on the elasticity score, look at those images over here. You find the image over here as hypoechoic and little lobulation. On the basis of grayscale image,